Hi, I'm Yasser Janab, interventional cardiologist in Tehran Heart Center, presenting the case transcatheter aortic valve replacement and percutaneous core intervention in a very low ejection fraction patient. Our case is a 56-year-old man with recurrent admissions for heart failure. Transthoracic echocardiography showed very reduced ejection fraction of 10%, very severe low flow, low gradient aortic stenosis, peak gradient of 50 millimeters of mercury, mean gradient of 29 millimeters of mercury, aortic valve area of 0.5 square centimeters. He also had severe right ventricular dysfunction, severe tricuspid regurgitation, PAP of about 70 millimeters of mercury, and moderate mitral regurgitation. Coronary angiography showed severe mid-LAD stenosis. For all of these reasons, CABG and aortic valve replacement were strongly refused by the surgeons. CT angiography showed bicuspid type 1A aortic valve, severe aortic valve calcification, calcium nodule at annulus extending into LVOT, and perimeter of 93.4 millimeters. It has been shown that patients with low flow, low gradient aortic stenosis should not be declined for transcatheter aortic valve replacement on the basis of left ventricular dysfunction severity or dobutamine stress echocardiography result. TAVR appears to be a good alternative treatment for patients with low flow, low gradient aortic stenosis and severe left ventricular dysfunction. In this document, it has been shown changes in left ventricular ejection fraction over time in patients with ejection fraction less than 30%, which improved significantly over 1 year follow-up. It has been shown also that changes in ejection fraction over time in patients with ejection fraction less than 30%, irrespective of contractile reserve. In a recent document by European Society of Cardiology guidelines, it has been stated that intervention should be considered in symptomatic patients with low flow, low gradient, severe aortic stenosis and reduced ejection fraction even without flow reserve, particularly when CT calcium scoring confirms severe aortic stenosis. Access was gained under ultrasound guidance, and perclosed pergolide suture-mediated closure system was applied for our access management. Before coronary intervention, pictal injection in aorta was done, and by using left implants and thromostrate wire, we crossed the severe stenotic valve. After placement of a pigtail through aortic valve in left ventricle, we managed LAD stenosis with predilation and stent implantation and post-dilation of LAD stent from left femoral artery axis. After fixing of LAD stenosis, we put a Python sheet, which is a 14-French expandable introducer sheet, in our main axis, which was right femoral artery. Our choice in this patient was Myval transcatheter heart valve with a size of 30.5 mm. Myval is a balloon expandable valve. After placing 14 French Python sheet and placing stiff wire in left ventricle, predilation was done. Afterwards, 30.5 mm balloon expandable Myval was implanted in appropriate position under rapid pacing. You can see the final result, which shows no parabolic leakage, minimal residual gradient. Follow-up after 2 months showed no readmission and mild exertional dyspnea. Transthoracic echocardiography also showed left ventricular ejection fraction increased from 10% to about 30%. It has normal functioning aortic bioprosthetic valve with no paravalvular leakage, and there was only mild tricuspid regurgitation with pulmonary artery pressure decreased from 70 mm of mercury to 30 mm of mercury. In conclusion, transcatheter aortic valve replacement appears to be a good alternative treatment for patients with low flow, low gradient aortic stenosis and severe left ventricular dysfunction. Thanks to our special team, Professor Mustafa Salarifar, Dr. Muhammad Ali Dusti, and Alfonso Lelasi. And thanks for your watching.